Thank you, Oncology Club, for inviting me to present here. I'm Dr. Sayera Banu Sheuly, working as Assistant Professor in Department of Chittagong Medical College, Department of Surgery, Chittagong Medical College. Breast conserving surgery is now considered the standard of care for breast cancer patient. As comparing to mastectomy, it has similar survival and recurrence rate, better quality of life, psychological well-being, and aesthetic outcome. When a patient with breast cancer comes to us for conserve her breast, after proper workup, we generally organize a MDT, and if NCT is planned, we go for marker placement and then proceed. Like any other cases, this lady with IDC triple negative cancer was planned for breast conserving surgery with NCT. As per plan, hydrogen marker was placed, and before operation, patient was sent for wire localization in imaging department. But marker could not be located with wire after several attempts. What shall I do now? Will I send the patient to higher center or do mastectomy? We know mastectomy has a deep and prolonged negative impact, and it causes severe mutilation and diminished self-worth, may threaten perception of femininity. Though marker was missing, surgeon still decided to do planned surgical procedure, that is breast conserving surgery. But how was it possible? And was it a wrong step? Do the audience differ with the decision? We have a photograph of scratching outlining the lump over the patient. Gradually, we had a photograph of scratching outlining the lump over the patient, and favorable tumor breast ratio, and ultrasound report showing the details of the lump, and patient expectation was not unrealistic. And what did we do? We do the breast conserving surgery considering the lump size of pre-neoadjuvant state, and margin clearance was done with frozen section facility. And this experience promoted us to do for this study. It was 10 cases, age group was 38 to 58 years old, conducted at Department of Surgery, CMCH, and in private hospitals in Chittagong. Our outcome measures was margin cleared, need for re-excision, NCT response evaluation, and surgeons and patient satisfaction. Inclusion criteria was early breast cancer with favorable breast tumor ratio, patients want BCS but having financial constraint, who gave informed written consent. And exclusion criteria includes retroareolar tumor, multifocal, multicentric tumor, and other factors that render breast conserving surgery contraindicated. In the procedure, patient was supine with arm abducted to 90 degrees as is placed in during operation. And tumor location, distance from tumor to skin, pec muscle, and NSC distance was assessed with ultrasonography that is shown in this format. Tumor was outlined according to the quadrant. Sometimes we also draw the surgical incision marking in this setting. A photograph of the breast was taken for reflecting the skin marking during the surgery. 1 centimeter margin clearance was adopted for partial tumor regression, and for complete tumor regression, the marked area of the tissue containing the tumor was removed with an ellipse of overlying skin up to the pec muscle. These are some photos showing our activities. Our lump size in new pre-NCT setting was 2.1 to 6 centimeter, but it was 0 to 4 centimeter in post-NCT state. 6 lump was located in outside the outer portion of the breast. In intrinsic subtyping, 3 was triple negative breast cancer, 3 was hard to enriched, 2 was luminal B, and 2 was luminal A. And for response evaluation, we can see that 4 tumor was completely disappear after the NCT. All patients shows clear margin after excision of the lump. No one need reoperation, and both patient and surgeon were satisfied regarding body image and cosmesis. In our setting, cost for marker placement and wire localization, usually it causes 40,000 to 50,000 taka. That means we could save at least 40 to 50,000 taka per patient. Now, question may arise, is it necessary to excise tissue based on pre-treatment size? Many surgeons routinely perform surgery based on pre-treatment characteristics rather than more appropriate post-treatment size. But a study shows that there is no need to excise the pre-treatment size. Now, anyone can ask me, as I did not take the advantage of downsizing benefit of NACT, why I gave NEOS. We know that the goal of neoadjuvant systemic therapy also includes prognostic information, and it acts as a surrogate marker for future. There are several marking technique, placement of metallic marker, radioactive seed, but in here we generally use hydrogel marker. But this systemic review have shown that despite using the marker, the incidence of unsatisfactory margin can vary from 5 to 23%. Because we know that marker can migrate, and the NACT response all time is not concentric, it may be eccentric, patchy, or haphazard. The challenge faced by a surgeon during BCS are twofold. To resect the tumor with a negative margin, we know that margin positivity is the sole and main point for local recurrence. And the second challenge is to maintain the cosmetically accepted breast shape, size, and contour that can be overcome with oncoplastic technique. And in our setting, we mostly adopted the oncoplastic level 1 procedure. This paper has rightly shown the barriers and challenges in providing standard breast cancer care in low resource setting. They have mentioned rightly that financial issue is a great concern, and we are trying to overcome this. Regarding our drawing, we are evolving with each cases, and ultimate target is the perfect one. So we can say that it is highly cost effective, an ideal option for patchy responder, though applicable in highly selected patient. I want to utter this one time more, that is highly selected patient and may result in suboptimal cosmetic outcome in the long run. But we can help someone to feel more positive, confident, normal, and strong. In conclusion, this novel cost-effective tumor localization technique demonstrates promise in improving access to BCS for underprivileged patients in Bangladesh. With further validation, this method could be a hope for the poor patient, otherwise mastectomy is the only option for them. Thank you.